I am Dr. Derek Lee, and it's my pleasure to introduce Dr. Manuel Rigo, who is the medical director at the Elena Salve Institute in Barcelona, Spain. He's also the founder of the Barcelona Scoliosis Physical Therapy School, and of course, the creator of the Rigo Cheneau brace. Welcome, Dr. Rigo.
Okay. Well, first of all, I want to apologize because you will note that I am a little bit out of shape in using my English, because during all this year of pandemic, I used to practice a little bit with patients coming from abroad, but this year I had no patients coming from abroad,
Yes.
and I was not giving lectures, and so that means that I am a little bit out of shape, but let's try.
Now, I was wondering.
Thank you for inviting me to be here.
My pleasure. I have lots of questions to ask you about bracing, of course. But first, I'd like to start off with how did you first become interested in medicine? And if you can take us through your career path to being a medical doctor and specializing in scoliosis.
There was no special reason for me to go into medicine. I liked very much biology and anatomy, all these kind of things. And when I was 17, I think I went into the career in 1975. I had to do it in Barcelona. I was born in Mallorca, but I have to go to Barcelona because in Mallorca we had no faculty of medicine. And in Barcelona, I was finishing in 1981. So at the fall course of medicine is when I met Gloria, who would be my wife, is my wife, Gloria Queda Salva, and Gloria's mother was Elena Salva, one of the pioneers of the physiotherapy in Spain. She was introducing this growth method in Barcelona in the 60s. So when I finished medicine in 81, my first specialty was about allergy and clinical immunology. And at that time, I asked myself, why not to go and help Gloria managing the clinic. Gloria, my wife, is also a medical doctor, and she was managing the clinic. So I put my attention then to the rehabilitation, physiotherapy, and bracing of scoliosis. So that means that my interest start around 1986, something like that. But coming from a totally different specialty. However, I think that at the end of the day, you are not choosing scoliosis. I think that the scoliosis chooses you. You know what I mean? It's taking you, and then once you go into this field, wow, it's very difficult that you put the attention in other things. Huh? It's amazing.
I think you're absolutely right. Now, I was wondering.
That's more or less.
Yes, the scoliosis is a crazy animal. It just gets a hold of you.
Yeah, it's so complex. Try to learn as much as you can from your colleague. I think that at that time I listened a sentence from I think it was in France in a conference, an orthopedic surgeon giving a lecture. I was very young, and what it was impacting me here from this surgeon telling that the treatment of confirmed scoliosis with potential for progression is a constant and unpleasant lesson of humility. And this really touched me very much. It's I think I started to observe my colleagues, and I saw that in this field, doctors and people working on this field were so, how to say, humble, no arrogant. In my other specialty, there was a lot of arrogance, and this field, everybody was very calm, very lack of arrogance, very humble. And this touched me very much. Yeah.
I completely agree because, as you know, I've interviewed quite a few surgeons, pediatric surgeons, and they're very, very humble and very empathetic in terms of with what they can do and with the children they treat. So I completely agree. What drove you to look for something better in terms of bracing?
Well, listen, in my first years, I was just prescribing the braces. And here in Spain, very popular the classical braces. I mean, we were using Milwaukee braces, Boston braces, and also Lioness. I don't know if you are familiar with this. The Lioness brace, which came after, normally after casting. So at that time in the 80s, in Spain, particularly in Barcelona, still following the French school, it was very popular, the casting adolescent idiopathic scoliosis, not only early onset scoliosis, but the Lioness brace was used basically to maintain the correction after casting. Okay, so this was a very typical protocol in Spain: casting, Lioness brace, physiotherapy. And then when I was learning about more and more about the specific physiotherapy, this Roth method particularly, which was based on three-dimensional principles, um, mainly the rotation. Okay, so we were looking in the physiotherapy, teaching the patient to correct themselves in 3D. They had to learn to produce regional the rotations and counter rotations, and then by elongating at the time they were derotating, they had to align themselves in the frontal coronal plane and sagittal plane. So looking at these principles, I was a little bit frustrated with the braces that were using, not because of the results, because results were at that time similar to no with this type of braces. I mean, for looking at the expectation of the people, we were not unsatisfied from the results, but from the fact that there was this lack of correspondence between what we were doing with the physiotherapy and the brace. Then at the end of the 80s, around 80, I think 88, something like that, I met Dr. Rigo Cheneau for the first time in Germany at the Roth Clinic. And I was very interested in his principle. He had been developing this concept of bracing together with Professor Matthias from Munster. I think they started in 1971. No, sorry, 79. And so that's the reason why in France, this concept was initially well known under the name of CTM, from Cheneau, Toulouse. Jacques Cheneau came from Toulouse, Munster for Professor Matthias in Germany. So CTM was the name in France, but slowly it was more and more popular, the name of Cheneau type brace. Okay. So then I found this system to be very compatible with what we were doing in physiotherapy, meaning the principle was also the rotation, frontal and sagittal plane alignment. So I was just attracted by that. And then during the 90s, this was a very highly creative, let's say, time. We were meeting very often together with Dr. Cheneau and also Dr. Weiss and Rudolf Weiss at the Roth Clinic. Weiss was organizing at that time practically every year a workshop on bracing. So we met a lot of people there discussing about how to improve the standards of that, because a standard was very poor. I mean, Cheneau was not a brace, Cheneau was a concept. And you had, let's say, so many Cheneau braces, like people doing it. You know, the standard was very poor. You could see, for example, 5 patients with the same curve pattern and similar morphology. And then you were looking at the 5 braces made by different orthotists under the name of Cheneau. And you say, oh my God, I mean, what, they are totally different, the braces. What the standard of that, okay?
Sure.
So this concerned us very much, and so my contribution was about describing the principle of the brace using biomechanical explanations rather than anatomical descriptions like Cheneau was doing then. I mean, Jacques Cheneau was explaining how to build the brace using anatomical description of the trunk deformity and so, not paying so much attention to the X-ray itself, but itself, but at the trunk deformity. And then I just tried to pass this into the biomechanic concept. And then I was developing the specific classification to decide about how to design the brace. So I had the illusion that this would increase the standard, would improve the standard of the fabrication of the brace. So I myself never called the brace I was doing Rigo Cheneau brace. I was doing a Rigo Cheneau type brace. And people slowly start to call it Rigo Cheneau. Is the way I do the Cheneau brace. And the way I explain the principle of corrections and using that classification, that's all. But it's not a product, it's a corrective device, that everybody can do, still very different. I am a little bit more satisfied about the standard looking back at the 90s, but not yet. I don't think there is a standard.
Are there any plans for the Cheneau type braces to be standardized across the board, or is this too late?
I am thinking how. I think it's too late.
Okay.
At least from my side, to do it from let's say observation, experience, empirism. I think to do it from scientific research. So probably using artificial intelligence, CAD/CAM system, all these kind of this line of research is gonna produce a good standard sooner or later for sure.
Okay. Now, I understand. One question I wanted to ask is that the Cheneau style brace seems to focus a lot on derotation in terms of very standard concept in scoliosis progression is RASO or RASO.
Yeah.
Right. Just to briefly explain that, as you know, it's specifically in the thoracic curve, you have an increase in either disc height or vertebral height at the front of the spine, leading from kyphosis to hypokyphosis, sometimes to lordosis. And that increases the anterior column of the spine. So to reduce the pressure in the spine, the spine rotates, and then that rotate produces the scoliosis. And you mentioned before that you used the Schroth principles and that thinking to design the principles with Cheneau for the brace, correct?
Mm-hmm.
Well, to me, it's the hypokyphosis followed by the rotation. Has you thought about bracing more into kyphosis to kind of reduce the curve in terms of bracing, or is it mainly a derotation concept first?
For me, this has been really a very conflictive issue in terms of, I mean, I had different thoughts during all my career. I was thinking in the 90s, I was really paying a lot of attention to this lordotic aspect of the scoliosis, the anterior spinal overgrowth. I was very concerned about these. I thought it had a primary role in the development of scoliosis, but slowly I was paying more and more and more attention to the transversal plane. So I was reading, I went back to the history and I was reading very much deeply the old papers from Roth and Somerville in the 50s and 60s. And then I was talking very much with René Perdriol, physiotherapist and biomechanics from France, that was describing very well the three-dimensional nature of scoliosis. Then I put a lot of attention to what Jean de Bosset, the French surgeon, was explaining about the three-dimensional nature. And particularly in 1992, Jean de Bosset gave a lecture in Montreal describing the three-dimensional nature of scoliosis. And this was in a book from the group that later would be the International Research Society on Spinal Deformities, the ERSSD. And in this paper, in this lecture, Jean de Bosset was really telling that or confirming for him that the driver of the lateral curvature, the frontal plane curvature, the driver was really rotation. So he said scoliosis is basically an horizontal plane deformity. And then I thought this is for most of the scoliosis I see this is true. I couldn't say which element of the three is the first, but much more later now. So I am more and more convinced that the scoliosis is basically a growth-induced torsion, and that lordotization comes secondarily from this torsional phenomenon. And the research made by René Castellijn in the last years, René Castellijn group is from Utrecht in the Netherlands, and he has been showing that the relative anterior spinal overgrowth is basically restricted to the scoliotic region. You can see this relative anterior spinal overgrowth in the scoliotic segments, but not in the junctions. In the junctions, the spine is more or less rectilinear, but it's not lordotic. And he has been demonstrating that the three elements of the scoliotic deformity, rotation, lateral deviation, and lordotization, are couplet. They comes together. And I think that the only way you can mechanically explain that is from torsion. So torsion means that the spine translates to forward, to the side, to back, can translate in any direction of the space from this moment of torsion, right? So it looks like the lordotization, like the lateral deviation, is a secondary phenomenon from rotation, from this torsional phenomenon, right? And as far as I think this is true according to my observation, and also looking at these old observations made by Rove and Somerville in the 50s and 60s. I think that most of the scoliosis are that way. Not all. You have different. I am convinced that in what we call adolescent idiopathic scoliosis, you have different things, right? But the most progressive type is the one where torsion, mechanical and geometrical torsion is let's say, the prevalent phenomenon. And then the lordotization, although being secondary, is a very important phenomenon because let's say, it becomes also a main factor for progression, because more lordotic the spine becomes, more unstable in the transversal plane is. So more progression you have, more lordosis you have, more the torsion can translate and deviate the spine. Okay, so I think it's a combination of all the things, but to my feeling, what is driving the scoliosis phenomenon is a torsion.
Okay, very interesting, because I know the Netherlands, the researchers there, and I've talked to Dr. Moyo Kroot as well. They seem to be approaching things from a little different point of view than the rest of the world. Very interesting. Yeah. Have you noticed that, well, if you have two patients, one is very lordotic,
yeah,
and one is very rotated, from your perspective, I've had other surgeons say that the more rotation is, typically the worse the curve is.
That's right, yeah.
Yeah. And is that more dominant than the lordotic nature of the spine? So if there's more rotation, it's going to be worse curve. If there's more lordosis, it's going to be an even worse curve, or what do you see?
It depends very much of the pattern of the curvature, and also the time for evolution. Let's see, classical, very, let's say, early adolescent thoracic scoliosis, okay? Producing from rapid growth a big moment of torsion. So making the spine to not only mechanically twist itself, the spine, but also to produce a big translation. This translation goes first forward and lateral, and then lateral and dorsal, producing a finally paradoxical hyperkyphotic scoliosis. It's not a real kyphosis, but a geometrical kyphosis coming from the torsional movement. Okay, so if you have long time for progression and you have a scoliosis producing a big arch of torsion, the moment of torsion translates the spine very much, then this scoliosis has a big potential for progression to, let's say, to reach a very high Cobb angle. Okay, and this scoliosis, normally you will be able to see the lordotic component most of the time, and they become paradoxically kyphotic very late in the evolution when they have a very big Cobb angle. And you can see clinically very much the spine sunken into the thorax. So you can see clinically the flat back phenomenon, and the spine protrude into the thorax. There is like an internal hump. Okay, other scoliosis, they progress with a very little, let's say, the moment of torsion produce very little translation forward, then immediately the spine comes lateral and backwards. So more the scoliosis goes forward, so more lordotic becomes, more the potential to progress to a big scoliosis. Less it goes forward, more it comes rapidly to the side and to the back. You can have even a significant rotation, but the Cobb angle is not progressing so much. Okay, so it's the combination of the three factors. I think all depends on which is, let's say, you could say the radius of the moment of the torsional translation. So more translation you have at the beginning forward into the lordotic direction, more chance you have to make a big scoliosis. And less you move forward, less you go into the flat back, less chances for a big Cobb angle.
I understand.
That's more or less the idea. This with some diagrams you can show this better, but I think the idea is clear. It's about this translation to be bigger or to be smaller.
Yes.
And all comes from rotation. Both cases, they can have the same amount of rotation, but one was translating very much and the other one was translating very little.
So the magnitude of the translation, you can predict the severity of the Cobb angle.
The initial translation.
Okay. With RASO or RASO, the concept is that the anterior column starts to increase, and that drives the lordosis, right?
Yeah.
Do you also believe that just in general, with rapid growth of the spine, that can also trigger the rotation and the translation issues, producing the scoliosis?
Let's say many children with flattening of her or his back, and not developing a skull at all, very many cases of symmetric flat backs, for example. So for me, the determinant element is the rotation, I think. However, I tell you, RASO plays a very important role in the potential for progression.
If you have a kyphotic, a hypokyphotic or lordotic patient, child.
With a scoliosis, you mean?
With a scoliosis, yes.
Yeah, sure.
And you were saying that it's the magnitude of the translation that develops how severe the scoliosis is going to be. How would you brace a child with the hypokyphosis, both with, number one, a small translation, and number two, a big translation?
Well, that's a very interesting question. I think that the main limitation for bracing is not the Cobb angle. I know that the SRS consensus paper is limiting bracing using the cup angle. Don't brace under 15 degrees, don't brace over 60 degrees, right? But I think that the real limitation for bracing is not in the cup angle, but is one in the flexibility, of course, and then in the lordotic component. More lordotic component you have, less chances to produce any good result, especially when using the type of brace that I use based on the rotation. Because at the end of the day, the spine is always looking for some balance. That means that if you have an important lordotization of your spine, then rotation used to bring the spine finally to the side and to the back, trying to find a good sagittal balance. And then you create also kyphotic compensations up and down of these lordotic segments, right? So when you put the patient into the brace, which is regionally derotating, by derotating, you bring the lordosis, which is in an oblique plane, you bring the lordosis into the middle sagittal plane of the patient. And at the end of the day, by derotating fully the patient, you would put the patient into a full extension. So patient need to do a kyphotic compensation up and down to be able to be balanced in the sagittal plane. So if you try to derotate more than you can, I mean, you bring the lordosis, this lordotic component, into the middle sagittal plane by derotating in a way that patient cannot compensate well, then you are lost. I mean, patient goes out of balance in sagittal plane, develop kyphotic compensations, and at the end of the day, there is no way to correct this lordotic component with a brace, because the brace is not able to apply any force directly in front of the spine, bringing the spine out of the thorax. You have no this element. I mean, you can derotate regionally a trunk. You can even align in the frontal plane, but you cannot apply any direct force inside the thorax, which is applied directly on the spine. You have to do it through the thorax. And as far as the thorax, when you have this flatbed, you have this lordotization, the thorax becomes wider in the transversal direction and let's say shorter in the sagittal direction. If you try to correct the lordotic component by doing flexion, and to do flexion, you push in front, the only thing you do is to deform the thorax more. So at the end, the reaction is that you get more flat back and more compensatory kyphotization. So this is the real limitation of bracing. When the lordosis, the thoracic lordosis goes inside, over a certain point, there is no way to go back. You cannot bring it out with the brace. So the only element that the brace allows you to use to fight, not to correct, but to fight against the lordotization is the breathing mechanics. Is by using the contacts of the brace, you produce a mechanism where when patient is inhaling, by inspiration, the sagittal diameter of the thorax increase and the spine is gently pushed back out of the thorax. But if this element is fully structural, mean that you have derotated so much that what have in the sagittal plane is a pure structural lordotization, there is no way that the breathing mechanics, bring the spine out. It's impossible. You can move nothing. There is no, let's say, force enough to do that. And so I believe that the real limitation of the brace is the lordotization. So when I have a patient with a big cup angle, big lordotic component, normally the rib ham takes an angular shape. I never brace. I learn, don't brace. Don't brace, because the only thing you do is to deform the ribs more, to create a more angular rib ham. you increase the lordotic component, and at the end you produce more instability. I would say that in that cases, the brace help the scoliosis to progress better.
Mhm.
I think it's a full contraindication for the brace.
I'm glad we talked about it because it's because you have a lot of orthotists just bracing everything they see, as you know.
Yeah.
Okay.
Yeah, and also I have colleagues that, for example, are waiting for surgery. For example, they say, put a brace, waiting for surgery. And I say many times, no, don't do it. I mean, it will be more difficult for you later on. Leave it to progress. Don't put a brace. In those cases, sometimes the Cobb angle is less than 60. So in some cases, I tell patients, don't get a brace, but I am less than 60. Listen, don't get a brace. It's going to be worse for you. And sometimes you have more than 60, but very flexible, not big lordotic component, round rib hump, you can still manage. So for me, it's not about the angle, the Cobb angle, what is limiting bracing, but it's about this structural lordotization.
Excellent.
Okay.
So basically, if a patient walks into your facility and they're quite lordotic, right away you're thinking not appropriate. But if there's a significant rib hump and there is there is kyphosis remaining with a curve, then you would have no problems bracing with that because that's the strength of the derotation brace, correct?
Yeah, that's right. If I see that clinically, I mean, I know I use some clinical exploration maneuvers to see what happened when I derotate and I produce a torsional force into the patient. And then in forward bending, you try to derotate. If you see that the rib cam is round, and by derotating, patient is still able to bend. I mean, you recognize the non-bending segment. I mean, the lordotic segment. You can see this very well. But you get some amount of flexion in this area, you can go forward. But if you try to derotate in forward bending and nothing happens, I mean, this is totally blocked. You can move nothing. And by taking the rib hand, you try to derotate and nothing moves. Bending forward bending, don't go for what?
Absolutely. You need a flexibility in the sagittal
Absolutely.
plane.
Yeah.
All right. Now I have some. Thanks a lot because it's clarifying a lot of information for me because I'm not able to find this information anywhere, and I'm glad we talked about it.
Thank you.
Now, a couple questions I have for you is that some doctors or surgeons feel, or even orthotists feel that when they're doing bracing, they should aim for maybe a 50% in-brace correction, right? But of course, not always possible, especially if the spine is quite stiff. Is that kind of a myth, or that 50% target, or?
No, I wouldn't say it's a myth. A myth comes from something, and this something is that it's true.
Okay.
That most of the series showing in the past good results from bracing, these series were showing some correlation between in-brace correction and end result, right? And also the main in-brace correction was close to 50. Of course, the main means that some people got less correction than 50 and some people got more correction than 50%. Okay, so I don't think that 50% is a target. This is just an information telling that in your series, to have some relevant and significant good results, you need to, as an average, be close to the 50%. This is an information for is a population target, let's say, but it's not individual, because not everybody, of course, accept 50%, and some people they get 50%, but 50% is not enough. They need more. And even with 50, they progress.
Mhm.
That's the point. So I think it's not a myth. I think it's a good target for a group, for a population that you raise, but it's not an individual target.
Okay. So if you were going to quantify the amount of in-brace correction, in your perspective, in general, what percentage correction would you always go for yourself?
It depends on very much on the rigidity of the curvature. Sometimes I cannot reach more than 20. Okay, so it's true that if I have a poor correction is defined less than 20%. I mean, at least at the moment, the information we have from evidence is that less than 20% can be defined poor in-brace correction. However, I have a colleague working in Austria, Franz Landauer, who showed that even with a poor in-brace correction, if you have a very compliant patient and the curvature has no big potential for progression, you can still stabilize. Okay, no correct, that for sure, no partial correction, but at least to stabilize and to reduce the rate of progression. So we used to explain families with a poor in-brace correction about the limitations we have, and they decide whether to continue or not with bracing. Then if I am over 30% in-brace correction, over 30%, and I feel that the scoliosis is more flexible than that, and I am always not satisfied. If I see more than 30%, let's say 35, okay, no compensations, no imbalance, and clinically I find the patient to be flexible, I always think about maybe I could improve the in-brace correction and reach this 50%, right? So I make a trial. I had in my life, I had to repeat many times braces because I was not satisfied. Okay. But then sometimes we need to recognize that looking for a higher in-brace correction, we correct more than we can, that the rigidity of the curvature accept. And then you always, in that cases, produce nocebo compensations. Especially is a problem the proximal thoracic curvature, the kyphotic, let's say compensatory kyphotic phenomenon, which come together with this proximal curvature. So this is very delicate. I don't nowadays I don't like to correct, let's say, looking for the 50% more than I can, because then the scoliosis, puff, is giving you this, you know. You cannot do more than you can. I remember very well also a sentence from Jean Dubosset, the surgeon, talking about surgery that I think you could apply also on bracing. Is maximum correction is not always the optimum correction.
Mm.
Okay, if you do this maximum correction, for example, with a brace using bending moments, and you produce bending, and this promote a compensatory proximal curvature, I don't think this is good.
Okay. So just to clarify, if you're hypothetically, if you have a 50-degree curve and you're going down to 30 degrees, and you feel that spine stiffness won't allow you to go beneath that, and if you force it, then you're going to have compensations happening in other areas, right? Because just from my research, it seems that some brace manufacturers feel that you want to overcompensate. And do you find, what's your perspective on that particular theory of overcompensating or overcorrecting in brace in the opposite direction to produce results?
No, I think this is product of the let's say arrogance on treating scoliosis. We cannot, my experience is that we cannot do that, because then at the end, the compensations are really a problem, especially proximal curvature. Yeah, it's a problem. So my current target is to reduce the Cobb angle as much as I can from the rotation, okay? Trying to maintain the transitional, the junctions, so the junction between the thoracic and the lumbar, and the junction between the middle thoracic and proximal thoracic, and T1 as close as possible into the central sacral line, and all made by the rotation, okay? And still being able, when the patient is into the brace, to me to observe that the function of the brace is good in allowing the patient to bring the spine out when breathing, okay? If I get very good in brace correction, no compensations, transitional points or junctions balance into the central sacral line, but then the function of the brace is not good from the dynamic point of view, I see that breathing mechanics doesn't work, the spine is not going out, but even going in when patient is inhaling, so you have a paradoxical breathing, I reduce correction always.
So you back off.
I make another brace, reducing the amount of correction. My first objective is no compensations, junctions balance on the central sacral line, and good mechanics. I mean, the breathing mechanics brings the spine out, so the function of the brace. So I don't care currently so much now about the in-brace correction. Yeah, I look at to learn, but I don't use it so much as a predictor of anything.
Mm-hmm. You're just hoping for stability, and it's a compromise, right?
Yeah. Okay. I have had always the feeling that long-term stability does not depend on how much you reduce the Cobb angle, but on how much you reshape the trunk. So no matter which is the final angle you have, I have the feeling that this angle will be more stable in the long term if the body is well shaped and the lordotic component is not so much.
Right, because the body can adapt and maintain that.
It's more stable. It's just more stable.
Okay. Another question I had is that the popularity of night braces has started to become a little bit more of a trend these days with the Providence night-based brace, and some orthotists are also doing double bracing. So they'll do a Rigo Cheneau type brace during the day, then a Providence type brace during the night. What are your first thoughts on that?
So question about nighttime. Yes. First of all, what I have to say, if I were adolescent right now, and I were developing scoliosis, of course, I would like to get a nighttime brace rather than a full-time brace. That's clear, right? However, I believe that in a scoliosis with big potential for progression, adolescent idiopathic scoliosis with big potential for progression, I think that there is a consensus that full-time is necessary. I mean, bracing is dose dependent. More you wear the brace, better the result. So for me, it's very sad to start bracing nighttime in an adolescent and recognize later that we need full-time. I mean, passing from nighttime to full-time is very frustrating for patients. So I rather prefer to start full-time in adolescent idiopathic scoliosis. I use nighttime as initial step in treating early onset scoliosis, in treated ALS. And if it's allowed due to the prognosis, okay? So in ALS, I use nighttime regime, and many times I see that these ALS patients, if they are good responders, they can pass even the adolescence period just maintaining the nighttime regime. But adolescent idiopathic scoliosis with tendency to progress, I think that nighttime is not enough. Then the decision about combining one design for nighttime and another design for the day probably is a good idea. I mean, normally you could try to correct more being in the lying position than in the standing position. So it could be it's a good idea. It's a good idea. I am not agree. I'm not against using nighttime different than daytime. I don't do it. I normally use the same brace for the night and for the day, just make the brace a little bit more corrective for the night. You know, that's what I do.
Very good. I have a question with respect to maintaining some sort of exercise as you were bracing, because just the way I'm thinking is that if you're bracing, then you're going to, especially full-time bracing, you're going to have a significant amount of muscle atrophy. Do you think that for patients who are bracing without some form of exercise, specifically Schroth or scoliosis specific exercises, that curves have more of a tendency to progress once bracing is stopped due to the loss of muscle strength?
So your question is, what about cases that progress after stopping bracing, right?
With or without exercise during
With
bracing?
and without exercise. First of all, physical activity is very important when you are bracing adolescents. I mean, the ISICO group from Italy, they have shown that active adolescents treated with brace, they get better results than passive adolescents. Just talking about general physical activity, right? So physical activity is important in that terms. Results are better. Also, we have some papers showing that those patients doing specific exercises used to lose less correction. So they maintain better the correction than those not doing a specific physiotherapy. But also this is, I would say, statistically significant. I don't think it's clinically relevant.
Okay.
So I believe very much it's important to do specific physiotherapy when you are bracing an adolescent, but I wouldn't be, let's say, very stressed about not having the chance to offer my child, my children, specific exercises if they are not available. I don't think that the end result is clinically so different with relevance. I mean, I don't think it's so different, right? So I think it's good. It's important to support. It's also a part of the, let's say, team approach. I mean, you maintain more close control the children through the physiotherapy. Let's say they adapt better to the brace. They understand better how the brace works. Let's say they maintain better muscle balance. Everything is true. But at the end of the day, if you have no chance to do a specific physiotherapy and you do at least general physical activity, the results are not so relevantly different. That's my opinion. Even I am a promoter of a specific physiotherapy. I think it's important, but I don't think it's, let's say, absolutely essential in treating a progressive scoliosis. The main job is made by the brace, and then the physiotherapy, it helps a lot, and it's part of the treatment. But again, I would, talking generally to the people, I would say people, if you get a good brace, don't be stressed about not having the chance to go to a good physiotherapy close to your home, offering you specific physiotherapy. What I don't think is reasonable, and this happens nowadays, is that people is traveling half of the world to get a specific physiotherapy. Honestly, I don't think this is reasonable.
Okay, excellent. Final question, if I may, and thanks for your time as well. Dr. Rigo, if I was going to give you 100 million euro, the best engineers and the best researchers,
Yeah.
how would you spend that in terms of trying to advance bracing technology?
Well, for me, the best approach nowadays is the approach that I have seen in the Labelle's group, Canada. I mean, I think this is a project that I would like to go. I mean, these are the three essential points are: first, let's select better the patients. I mean, Labelle was presenting in the social meeting in Lyon a very nice lecture telling or stating bracing works, but how can we do it better? The first thing is selecting better the patients. I mean, being able to predict progression individually. We don't know that, okay? So we are in the way to learn from this group about that and from other groups. For example, in Paris, you have the Dubochet group with the Scully working on the severity index. So trying to find something telling us individually, this is the risk for progression. So this allows us to select better the patient that we treat first. Second, good responders. Who is responding well to the brace? I have been always convinced that the brace itself, the forces produced by the brace cannot, let's say, modulate growth. I don't think. Experimentally, I know this is true, you can do that. But in practice with the brace and the scoliosis, I don't think you can do this. What you do with the brace is to put the patient into correction, and then this correction produce some type of signal, mechanical, neurological, biological, I don't know what, that makes some people to be good responders. So they correct themselves from the correction you put into the brace.
Mm-hmm.
So to understand this, I have always explained the same example. You can have two girls, same age, same morphology, same curve pattern, same cup angle, same amount of lordotization, same in-brace correction, same brace, same exercises, and you do all the same, and then one is progression and the other one is correcting partially.
Mm-hmm.
And we have no idea why. So probably these good responders, one of the reasons could be some biological factors, sure, some mechanical factors, but I am convinced that are more biological factors. So this is another, let's say, line of research. So biological factors converting people in good responders, because these open the door to the future. For example, let's imagine that someday we could treat all the scoliosis patients with nighttime brace plus medication, converting them into good responders, like we are doing in EOS, in early onset scoliosis. We don't know why it happened, but it happened. Some EOS respond very well to nighttime, and they don't need full time, and they pass adolescence with no brace. Okay, so knowing about good responders, and then improving the brace quality. So looking for which are the best mechanisms for correction, how to do it. And that research is made nowadays by using CAD/CAM, by using simulation, by using finite element models, by all these, let's say, take a lot of money. Okay, of course, I don't have this money. I am just a simple clinician working in Barcelona in a private clinic, so I cannot do all this research. So that's why if I would collect some money, I would put this money in people that already started this type of research. So my money would go probably to Canada, right?
Yes, and I've talked to Dr. Stéphane Parent and Dr. Aubin as well about the prediction models for in-brace, and he's also done prediction models for tethering as well. So very interesting because he's also thinking about developing a little bit of a different brace with the simulations as well. So I understand. You would allot all your money to Canada. I like it.
Yeah, I think, I have been always doing this from my, let's say, observation, experience, empirism. The experience is there. So I think that all these kind of elements, simulation, algorithms, etc., are very good tools. But you need the experience also. You need to of course, to know what the scoliosis is in 3D, how to correct from movement. I mean, that probably, let's say, a task force putting together people who has experience in correcting scoliosis manually by moving. I mean, putting all together in a table and looking one to the others, learning from the others. This would be very, very important. I would like to have all these tools to see how what I do in practice works in theory, how it works. I would like to know. But again, I don't have the money for that. Okay.
We'll have to work on that somehow.
Yeah. And the people who has the money sometimes and had very good tools, but then it's very frustrating because they don't have the experience about how to correct, and they go at the very initial step where you were, and then, oh my God, you will need years to you know what I mean? It's
Yes.
I think we should look at one to the others, people with clinical experience and people with money to make research.
No, I think you're completely right because you need the science, but you need the practical skills and the years of experience to get the best results overall.
Okay. Yeah, that's right. Yeah.
Okay. So Dr. Rigo, thank you so much for making yourself available for the interview. Learned a lot, and we'll see where scoliosis treatments takes us in the next 10 or 20 years. It should be interesting.
You're welcome. I'm very, very glad to be with you here and to share with you my experience. And I am always looking forward and very positive. I mean, many doctors working in this field, and you realize that doctors working in this field, we have a big resistance to frustration. Right, is necessary, and we are always positive, looking for learning more, to do it better for the families, for the patients, for the society. This is the idea. And I always think that the diagnosis of adolescent idiopathic scoliosis shouldn't be a drama. For many patients, for many families, is a drama. I think you can manage. I mean, you can live with an adolescent idiopathic scoliosis. Sometimes it's not so important. What my feeling is that even more important, the acceptance and the way you wear your angle, no matter whether you are operated. This is just a feeling after many years being with people and families. One of the nicest sentences that I think I can offer to the patients and the families is not so important the angle you have. At the end of the end, you don't wear a number in your back, but how you wear this angle. I mean, the way you accept your condition. I mean, you see adults with scoliosis in a very simplistic way. You can divide it in people doing fine and people doing wrong. And in both groups, you find people operated, non-operated, with big curvature, with small curvatures, people who were braced, people who didn't. I mean, we treat the spine, okay, but what is making adults with scoliosis being in one side or in the other, of course, is depending on what you have in your spine. But the main factor is the way you live your scoliosis, the way you wear it, So you have people with big scoliosis doing totally normal life, and we don't need to tell them, you are wrong. You have a big scoliosis. Don't be so happy. You are wrong. No, if they are doing fine, they are doing fine. you know, and people with very, very mild scoliosis that are completely destroyed. They have a not normal life. All their life is my scoliosis, my scoliosis. And sometimes we are tempted to tell them, but your scoliosis is a very mild, you have nothing. No, no, you have something. You were very wrong what you have. Your little scoliosis for you is a very big problem. And as a medical doctor, for me, the problem is not your spine, it's you. Is whether you do it fine or not. You know what I mean? So I think this message for the families is very important. Do the best you can for the spine of your children, for sure, right? But also do it in a way that at the end you are not fabricating, let's say, a patient, somebody that no matter the final angle will be unsatisfied, will be unhappy, will be not accepting the condition, right? That's, I think it's a good message for everybody.
Thank you, Dr. Rigo. I think that's a perfect way to end this interview. Thanks very much for your time, and we'll talk soon.
Thank you very much. Indeed. A pleasure to be with you. Bye, Dr. Lee.
Bye.